I think that if we're going to talk about vascular access, we need to understand that there's still significant education that needs to happen in this arena. So one of the panelists here wrote this great paper that everybody should read and delineates the best practices for femoral access. Actually, Manus was the last author. That need fluoroscopy, ultrasound, micropuncture access, and femoral angiography. I think that there are many aspects of these innovation that, many aspects of these practices that where innovation could happen. So a few years ago, we did this survey, and it shows that there's a significant gap in education, as most of the world is getting access using just palpation. In the majority of cases, and palpation of fluoro in a minority of cases. Here in North America, we're using palpation only in a third, palpation of fluoro in another third, and palpation fluoro and ultrasound in another third. So only a third of operators are following the best practices for femoral access, as noted in the paper by Yader. In addition to that, not everybody is doing a femoral angiogram to understand where the access occurred, and then micropuncture access may be beneficial, although the data is not there yet, but is used in only a third of the cases, in the majority of cases in the US, and it's almost not used in the rest of the world. So innovation in education, the online book that was edited here. Here is a nice picture of Dr. Pinto. And I think that this is a very innovative way to educate the people. I have a card here with the electronic book on my pocket that was given to me during the meeting, and I think it's a very nice way to start. There's a significant need for closure and access and closure innovation. Vascular access is crucial for patient safety and procedural success. You can do the coolest and the nicest CTO or a structural heart procedure, but then if you fail access, the patient dies and then the procedure goes through the drain. All procedures need to be innovated to increase safety, patient comfort, and a simplified approach. And then there are new structural interventions that will require creative and innovative solutions. One way that I thought was very innovative using just ingenuity is this innovation dissemination in Twitter. So Jason Wolmuth, who I have seen here, I don't know him in person. I think I saw him at a couple of sessions here. Published this in Twitter, and it shows that you can actually obviate an extra access when you're doing Impella by just sticking in the diaphragm of the larger access sheet that comes with Impella. You have to use a long hydrophilic coated destination sheet to go on the side, and you just can complete your case through the side. I think that's very nice to disseminate innovation. It's very ingenious, and I think that that's one way of doing things. Snuff box distal radial access has come as an innovative way as an alternative to use the arm for access and to preserve the radial arteries from many sticks. It also may be a comfortable way for patients that are obese and they cannot really move their hand because of some orthopedic impediments. So that's a nice alternative, an innovative way. This is a dissection. The education courses are also very innovative, and Mary came up with a new specific band for the snuff box for hemostasis. Innovation in ultrasound vascular access. I saw this from the Japanese operators, and here they have a T-shaped probe that gives you two different planes. So you have the regular plane that we use to get access, and then you have the longitudinal plane in the same monitor. So I think that that's also a very nice way to facilitate access using a needle guide that allows you to stick on the anterior wall of the vessel. And also you identify exactly what part of the vessel you're trying to stick. So that also almost eliminates the famous learning curve. There's also the finger mount ultrasound probe. I have seen this in many meetings. At AIM Radial, they're using in the Department of Defense just to identify wounds and to do quick ultrasounds in the field, but this is a very intuitive way because that allows you to use your other hand just to palpate instead of just holding on to the ultrasound probe. Then there's also a need for safety. We all have a horror story to tell about retroperitoneal bleed that we realize a few hours later when the patient is in shock and in need for multiple transfusions. So there's this bleeding monitoring using bioimpedance that's being studied by Soranas. This is the early bird monitoring device that can actually monitor whether or not the patient is bleeding at the access site. It can be integrated in the flow of the case. This was presented by Philippe Genereux at SCAI in 2019, and they can detect 3 different levels of bleeding, and in this case, no bleed was detected in 35%, but in the other 2/3 of the cases, there was some bleeding detected. In the majority of the cases was a level 2 bleeding of 127 milliliters. So that may be an interesting way to monitor bleeding and increase safety. Innovation for large bore closure, we've been using 2 proglides so far. We have adapted using ingenuity from smaller sticks to larger bore sticks. So we have the Manta that is now approved by the FDA, and then we have PerQseal and InSeal that have CE approval. Here is the Manta device. It's endoluminal absorbable toggle. So, and then there's a hemostatic bovine collagen pad that goes outside of the vessel. Doesn't require pre-preparation of the vessel. They come in 14 and 18 French, and you can close up to 22 French holes. It's FDA approved, and now it's being now adopted in practice. It's relatively expensive, so hopefully has a chance to go mainstream. This is a pivotal study that was done in the U.S. And shows that the procedural success was about 97.7%. The time to hemostasis was about 24 seconds, and then there was a low rate of vascular complications of about 4.2%. These complications were 4. 1 was treated with a covered stent, 3 had access site bleeding, and 2 underwent surgical repair, and 2 underwent just balloon inflation. There's the other device called the closer. It's for large bore vascular access, and here you deploy you deploy a plate inside the vessel, and then 2 small spheres on the outside that are fully resorbable. Then there's the InSeal VCD, which is a self-expandable nitinol frame covered with a biodegradable membrane. The device can be delivered through the procedural sheath, and there's no pre-procedural manipulation of the vessel that is required. It can close 12 to 21 French punctures and can allow also closure of the vessel. There's a study that's been done already. Data looks promising, and then they have added an additional seal on the other side just to improve the performance of the device. PerQseal is another device that is being also tested, and it's also innovative. And it's very similar. There's no suture, collagen, or metallic components. It's fully absorbed in 6 months, and neat vessels of at least 7 millimeters. In the Frontier 3 trial, there was 97% technical success and about 5% minor device complications without major R2 complications. So the other innovation in access is Transaxillary Access, which is the innovative part is the percutaneous use. So there are a few champions in the country that are teaching this technique. I think that it requires, there's a significant learning curve, as is shown here from this German experience. You can see that in the first 25 cases, the need for stent grafts, minor vascular complications, minor bleeding, were significantly higher, and then as physicians get more facile with the technique, the rate of complications is significantly lower. Transcaval access, we have been listening about transcaval access for a few years now. Everybody knows that there's a need for a better closure. This was the closure system that was presented by Toby Rogers at CRT in 2019, and allows keeping the wire through access just in case you cannot deploy it right, you can deploy it again. The covering devices that are used are adaptations from VSD closure devices or ASD closure devices that doesn't allow you to keep the wire in place. So I think that, that this may be promising. This is how it's delivered. This is how it looks at the end. And this is a nice CT scan showing the device. Suprasternal aortic valve access. Suprasternal access for valve replacement is also very appealing. There's this device that goes in the suprasternal fossa, and like mediastinoscopy, so a surgeon can easily get access in the fossa, and then you have direct access into the aorta, and you can deploy a couple of plagets and do a very easy TAVR from the suprasternal approach, and then the patients have a very minimal pain, and they can walk they can get up and walk in a few hours. Transapical closure innovation. I know how much innovation this is because I've been looking at this, and I went back in the literature, and this is from 2014, and I haven't seen this, at least in our practice, in our hospital. I don't know if you have had exposure to these type of technologies, but these technologies have been repeating and at different lectures, at different venues, and in different journals over and over. These are different types of devices that can be delivered at the apical site. But the problem with the transapical access is that this type of access is falling out of favor, as we have found that transaxillary access is becoming the most favored alternative access for large bore interventions. So just to conclude, there's a continued need for education and training, and I think that we have to be innovative on how we go about that. Radial approach continues to expand, and it's a favored access, and it should be the preferred access because of increased safety. New approaches, techniques, dissemination of knowledge in social media. I think it's important where we can share more and we can learn more from each other. This is a very active field that is fertile for innovation. And most of the action will occur in large bore access and closure and alternative access because of the need for new procedures and new interventions. Thank you.